Hi, we'll go ahead and get started. I'm Eric Ensrud. It's nice to meet you. I have been involved with Osler for quite a long time. I took the course myself for the initial board certification and then have been teaching for Osler for about 12 or 13 years and have done the recertification through Osler as well. I know we have both groups here today. So I'm going to be meeting with you guys each of the next 3 days, today and then tomorrow, and on Sunday morning as well. So we're going to focus this morning. I'm going to do 4 different topics this morning on different aspects of neuromuscular disease, nerve and muscle disease. You know, in neurology, we tend to get very subspecialized, and some of you may practice in this area and others may encounter it very rarely. So we'll go over important things to highlight for the board exams. I'm going to talk a little bit, just briefly, because we get bombarded with advertising, particularly I think in neuromuscular disease because the drugs are so expensive. There are some new drugs that have come out, but I've been assured by a couple of board members of the ABPN that it's 2 years from the time a drug is approved by the FDA to it showing up on board exams. So I'll mention them, ones that have come out in less than 2 years, just because if I don't, people will be asking, what about this? But just be reassured that to not focus on those too much unless they've been out for 2 years, and we'll mention that here. So we're going to start with motor neuron disease, ALS, an overview, and then whenever the AAN has come out with a practice parameter, that's a real high yield thing for the board exams. Tend to pull a lot of questions, and there is a practice parameter for ALS, so we'll go over that. And then we'll touch on spinal muscular atrophies as well. So what we're going to do first here is review the clinical syndrome in ALS and the care of ALS patients and talk about the natural history, the diagnosis, again, these ALS practice parameter recommendations, and then go over an overview of spinal muscular atrophies. So ALS is kind of a unique disease. It's really a clinical diagnosis, and there are 3 things that you need to diagnose ALS. You have to have all 3 of them. And one is upper motor neuron involvement, and the second is lower motor neuron involvement. And then a real crucial thing here is progression. So you really have to have all 3 of those to make the clinical diagnosis of ALS. And just some demographics. It's fortunately not a very common disease. It's certainly particularly in recent years since that ALS plunge, or how many of you pour cold water on yourself like I did? So it's gotten a lot more publicity, but it's about 2 per 100,000 incidents. It's slightly more male, and the peak is in the 60s, but it can occur in people from the teen years to the very elderly. And this is somewhat of a moving target, but a subset of the patients who have ALS have a hereditary reason for it, and some of the patients that have sporadic ALS, a subset of those, have a mutated gene that it's not exactly certain. But of the hereditary, the one really well-defined cause of ALS is the SOD1 gene mutation, and we'll talk about that's about 20%. The most common hereditary form is this C9orf, or open reading frame 72, which is a repeat. And like all repeat diseases, the longer the repeat, the more risk for the disease. Repeat diseases, and we'll talk about a number of them today because there are a number of neuromuscular diseases that are repeat diseases. They're always high yield for the board exam. So these 2 populations of cells, the white one, the upper motor neuron going from the motor cortex down to the anterior horn cell, and the yellow cell, or the lower motor neuron, going from the anterior horn cell out to the neuromuscular junction. those are our two populations we're interested in ALS. And so the pathology, there's significant atrophy of the corticospinal tracts. And you may see an image like this on the board exam. And this is myelin stain, of course, of the spinal cord. And we're lacking myelin stain where the asterisks are, where those lateral corticospinal tracts are. And so when we try and make the diagnosis of ALS, we need to look for upper motor neuron symptoms, and you may see this in a vignette. Things like loss of dexterity, slowed movements, and we'll talk a little bit about the loss of muscle force in a UMN or upper motor neuron pattern, a stiffness and spasticity, and emotional lability or pseudobulbar affect. And so the upper motor neuron pattern weakness is real easy to remember if you remember the last time you saw a patient who'd had a hemiplegic stroke and they walked, into your clinic room or down the hallway and walked with the arm flexed like this and the arm and the leg extended. So the upper motor neuron pattern is that the flexors are stronger than the extensors in the upper extremity. So for example, the biceps retains a lot more strength than the triceps. And then in the lower extremity, the extensors, it's just the opposite. The extensors maintain a lot more strength than the flexors. And it looks abnormal, but it's actually a very functional adaptation and gait pattern that allows people to keep ambulating after unilateral hemiplegia from an upper motor neuron problem. And sometimes even in ALS we can get this pattern. It's often not picked up, but patients with ALS can present with hemiplegia. So upper motor neuron signs are things like this pattern of weakness in the upper extremity and a Hoffman's spasticity and abnormal deep tendon reflexes. And then in the lower extremity, there are things like upper motor neuron weakness and, again, abnormal reflexes and the Babinski reflex. One thing you have to remember about reflexes in ALS, though, is that you're simultaneously affecting the upper motor neurons and the lower motor neurons, and you can't have increased reflex with severe injury to the lower motor neurons because you can't get the signal out to the muscle to contract. And then bulbar reflexes are important, particularly a jaw jerk, a very abnormal reflex that places things above the cervical spine. Dysphagia and dysarthria are really common in ALS patients. I'll show you a picture of an ALS tongue in a moment, and that's easy to realize why that would be, dysphagia and dysarthria would be real prominent. And then those are distinguished from lower motor neuron symptoms and signs, and we have our lower motor neuron here. Loss of muscle strength, atrophy, so that's much more of a sign with lower motor neuron than upper motor neuron. Fasciculations, or individual motor nerve cells that are firing spontaneously and causing the group of muscle fibers they innervate, like this little log right here, that group of muscle fibers to spontaneously contract. Muscle cramps, and you can also get dysphagia and also dysarthria from lower motor neuron. So occasionally we'll have old slides in here, and I've thought about updating them, but I don't really want to take a picture of one of my ALS patients and put it in things that are going to be broadcast. So I don't know who this gentleman is, and I apologize to him, but it's obviously quite an old slide. But head drop is a real common finding in ALS. It's not specific to ALS, and upper extremity atrophy in particular is really common. And if you think about how the motor neurons are distributed along the spinal cord, they're not uniform. You've got that enlargement of the cervical spinal cord because you have so many motor neurons going out to your arms because you have very fine movements, for example, in your fingers, and you need really small motor units as opposed to, say, your quadriceps or your hips, where one motor nerve cell supplies a lot of muscle cells, and the movement is not so fine. So upper extremity involvement is really common, even early on in ALS. And sometimes you can get asymmetric involvement, very asymmetric initially. So with this right calf being atrophic compared to the left. And this is a ALS tongue. You get slow movement from the upper motor neuron or cortical bulbar fibers, and then you can get, as ALS progresses, really severe tongue atrophy. Those of you who have worked with ALS patients, you'll know that over time a lot of them start speaking like this because their tongue's not moving as well. That's always a concerning sign when someone comes in with stiffness and fasciculations and has that sort of voice. And so ALS pathogenesis is not entirely determined. There are lots of theories, and with a particular gene we know the mechanism, but the problem is these cells are so long, going from the anterior horn all the way out distally in the arm and leg, and they're subject to a lot of stress doing the axonal transport over those great details. So probably this is kind of a common mechanism that many different pathologies can work through, and the common endpoint is motor neuron cell death. There are some risks. Smoking and extreme exercise, it's more common among people who are, example, marathoners or extreme endurance sports. Some evidence from Northwestern in town here for pesticide exposure. Some evidence that veterans are at greater risk, whether it be from them